Hello, I'm going to be touching on phage therapy to treat urinary tract infections, specifically catheter-associated urinary tract infections, or CAUTIs. We're going to be touching on the medical device regulations in this presentation. The focus may be on phage therapy, and we may identify some contributing factors to antimicrobial-resistant urinary catheterization devices, as well as evaluating the promises and the pitfalls of phage-based interventions in treatment and prevention. We're going to explain the regulations and regulatory gaps for urinary catheterization devices in the United States and compare them to Belgium and Australia by analyzing current and emerging policies of regulating agencies, the Food and Drug Administration, or FDA, the Federal Agency for Medicines and Health Products, or FAHMP, and Therapeutic Goods Administration, or TGA. We live in a post-antibiotic era where drug-resistant microbes run rampant in healthcare and agriculture. Globally, in 2019, AMR was associated with almost 5 million deaths, a quarter of which were directly caused by AMR bacteria. Drug resistance has been an enduring concern since the dawn of pharmacy, especially after the United States made penicillin available to the public following World War II. In his 1945 Nobel Prize lecture, Alexander Fleming, the discoverer of the first antibiotic used widely, penicillin, said, "The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant. The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism." Today, nearly 1 century after Fleming's discovery of penicillin, an event that ignited the golden era of therapeutic research, development, and regulation, our modern antibiotic arsenal has dried up. Over the past 2 decades, FDA under the US has approved only 2 new classes of antibiotic compounds against gram-positive bacteria. Meanwhile, the prevalence of superbugs continues to rise. By 2050, AMR is on track to kill 40 million people worldwide. The 21st century desperately needs another golden era in research and development for alternative therapeutics, particularly precision-based and future-proof medicines, in order to regain control over bacterial infections and manage AMR as a global health crisis. Traditional antibiotic compounds target a variety of mechanisms to destabilize or thwart bacterial function and reproduction. Bactericidal drugs such as penicillin or fluoroquinolones kill bacteria, while bacteriostatic drugs such as macrolides and tetracyclines halt reproduction, leaving the body's immune system to clear the infection. Of the 1,500 known species of bacteria that cause disease in humans, 6 species, titled the escape bugs, are remarkably concerning, cited by the World Health Organization as priority pathogens for research and development. Bacteria develop resistance through a plethora of mechanisms: efflux pumps to shuttle antibiotic compounds out of the cell, enzymes to degrade or inactivate the drug compound, mutations that modify the drug target, or mutations that limit drug uptake. Whereas antibiotics subject bacteria to strong evolutionary pressures to evolve countermeasures of resistance, social and economic drivers of AMR are critical to acknowledge. Here we highlight the clinical burden of UTIs. UTIs are a very significant component of antimicrobial resistance. UTIs are particularly disruptive to public health not only because of how ubiquitous they are, but also because they're uniquely prone to antimicrobial resistance. One study in 2019 found that of the bacteria causing UTIs, 92% were resistant to at least one antibiotic, and 80% were resistant to at least 2. Oftentimes, UTIs cannot be treated with the traditional antibiotic therapy due to biofilms. These are sticky, nearly impenetrable layers of bacterial colonies that build up in the urinary tract, especially on catheters in the clinic as well as kidney stones. The clinical and economic burden of recurrent UTIs is enormous. Historically, about 50% of women contract at least one UTI in their lifetime, and 20 to 30% of those experience a recurrent infection, costing the U.S. economy $3.5 billion per year. A patient who experiences recurring UTIs is usually prescribed long courses of antibiotics. This can damage the beneficial microbial communities that preserve physiological stability, well-being, and even the mood of the patient. One study revealed that globally in 2019, there were over 405 million UTIs, 5% of the world's population, with some 3 million hospital visits, many of which involved recurrent infections and 240,000 deaths. UTIs have also been linked to mental health issues such as anxiety and depression. With the advent of human microbiome research, the traditional approach to use static chemical compounds to control bacterial infections is being transformed into individualized, precision-based therapeutics. Multiple analyses suggest that UTIs are associated with dysbiosis, or an imbalance of the individual's microbiome, in the urinary tract, often caused by strains of uropathogenic E. coli, or UPEC. Bacterial biofilms are commonly associated with persistent and recurrent UTIs, while CAUTIs, catheter-associated UTIs, are the most common reason for hospitalization. Additionally, complicated UTIs, which means multiple causative agents contributing to the infection, and urosepsis, when a UTI spreads to the bloodstream, are especially concerning and necessitate alternative therapies and innovations such as nanotechnology, novel peptides, and of course, bacteriophages. Catheter-associated UTIs are a major issue in hospitals, especially in nursing homes where antibiotic treatment cannot appropriately be used in about 40 to 75% of cases, leading to significant clinical and economic burden. Bacterial biofilms are commonly associated with persistent and recurrent UTIs, and CAUTIs, as I mentioned before, are the most common reason for hospitalization. Complicated UTIs and urosepsis are concerning when there's alternative therapies and innovations that necessitate new things such as bacteriophage therapy. And that is undergoing a renaissance in Western biomedicine, which has spurred substantial economic interest over the past 2 decades. Major markets of phage applications include agriculture, water treatment plants, industrial appliances, and topical cosmetics, yet phage therapy in clinical medicine is largely unregulated. Analyzing the regulatory framework of phage therapy to treat CAUTIs enables researchers to design effective clinical trials and gather valuable data on phage therapy. By comparing the current regulatory frameworks for phage therapy in 3 countries, the United States, Belgium, and Australia, we can identify best practices for advancing phage therapy as an alternative method for treating CAUTIs. Next, I'm going to touch on the medical device regulations for catheter safety. A biofilm is not necessarily going to lead to a catheter-associated urinary tract infection. One excerpt from the Infectious Disease Society of America labels that CAUTI diagnosis requires first the presence of symptoms or signs compatible with a UTI such as fever, pain, malaise, and no other identified source of infection, as well as at least 10 to the 3 or 1,000 colony-forming units per milliliter in the urine. According to the FDA, they instructed people to refer to guidelines for a complete description of CAUTI diagnosis and catheter-associated bacteremia within one study that's shown here on the screen. Medical devices are defined, I'm going to use the definition from the European Union. This means any instrument, apparatus, appliance, software, implant, reagent, material, or other article intended to be the manufacturer to be used alone or in combination for human beings for one or more of the following specific medical purposes. And we're going to focus on external, intermittent, indwelling, and suprapubic urinary catheters as medical devices here. External catheters, also known as condom or urodome, these are devices that adhere to the external genitalia. The advantages of these is that you have a lower risk of UTIs, pain, and death compared to indwelling types. They're safer and more comfortable for patients, and they're more practical for incontinent elderly males when there isn't a permanent tube suitable for them. The disadvantages here is that it can cause tissue damage if it's placed incorrectly, it may not drain the bladder adequately, and it's currently only available for male patients. The intermittent catheters are described as a temporary PVC tube inserted via the urethra and removed immediately after the bladder empties. The advantage here is it's better for mobility, independence, and body image, and there's a lower incidence of CAUTIs. The disadvantage is that it requires a competent patient to perform or manage it, maybe for themselves. It requires frequent insertions, and that can lead to urethral trauma, and it's less effective than indwelling catheters for treating chronic urinary retention. Indwelling catheters are the ones we will focus on primarily here, Foley or IDCs. This is composed of a tube held inside the bladder by an inflated balloon. The advantage here is that they can stay in place for up to 1 to 12 weeks. They're highly effective and standard treatment for urinary retention, but the disadvantages is that it has the highest risk of infection, most associated with CAUTIs among all the different types. There's a higher risk of injury to the urethra or bladder, especially during insertion or removal, and there's a high risk of self-extraction by patients who may be confused or delirious. Finally, there's suprapubic catheters. These are inserted to the bladder through a surgical opening in the abdomen. These have long-term use. They stay in place for months. They allow the use of a valve to control drainage rather than a constant bag, and that's advantageous. However, some disadvantages: there's risks associated with the surgery, such as injuring the organs. They're difficult to insert and maintain, particularly in obese patients, and patients may experience urine leakage through the urethra. So let's focus on the United States and CAUTIs and strategies to address microbes on medical devices here. So first, the FDA has identified two primary ways that they can address microbes on medical devices. First is preventing microbial adherence to form those biofilms. Second, if they've already adhered, how do we remove or inactivate those microbes? Phages might be able to address both of these. But just to talk on CAUTIs, from their website, they state conventional and antimicrobial Foley catheters are described under a very specific regulation called 21 CFR 876.5130A, long name. They're called the Urological Catheter and Accessories Regulation, which is defined as a flexible tubular device that is inserted through the urethra and used to pass fluids to or from the urinary tract. Some recommendations they have on here. Within that regulation, it's important that you conduct labeling, proper labeling. You have biocompatibility testing. Third, there is performance testing for the device. That includes flow rate testing, the inflation of the balloon if it has one. Fourth, making sure that you have information on the sterility of the device. And fifth, that there is performance testing for antimicrobial features if those are on there, so only if that is applicable. Something that is noted within this regulation is that functional and performance data for the antimicrobial component used as a coating or integrated into the device material should demonstrate that the antimicrobial is effective, in reducing the incidence of relevant nosocomial infections and that it is proven to be safe. So FDA has technology goals for CAUTIs. Their goals, this have been for the past 10 plus years. First is they want to reduce the incidence of CAUTIs, or they want to treat CAUTIs. Again, addressing that prevention or treatment. They want non-toxic or low-risk devices for all populations susceptible to CAUTIs. They want prolonged effect for the duration of the indwelling time. So this is without degradation from the environmental conditions. And they also want it to be effective against multiple uropathogens. Remember, we talked about complex UTIs, and not selective for other pathogens. So the CAUTI rate is low among those who are catheterized. It's up to about 5%, and this necessitates us to have a large clinical trial to actually demonstrate there is a reduction in CAUTIs should we introduce any innovations. Second, let's look at Belgium. Belgium is regulated under FAHMP, as I mentioned before, under the regulation 4.2.1, the non-invasive devices, and then we can look at 4.2.2, invasive devices. So first, the rule here, 4.2.1, these are devices that do not come into direct contact with the patient or contact the intact skin only. So the general explanation of this rule is that all non-invasive devices are classified as class 1, meaning very low risk, unless one of the rules is set out that contradicts that. So these are devices intended in general for external patient support, including hospital beds, as well as some catheters, and body liquid collection devices that are intended to be used any way that return flow is very unlikely. There's another regulation that determines whether it becomes class 1 or class 2. Are these devices invasive with respect to body orifices? Are you sticking this inside of a body orifice? If you are, it's going to be higher risk and probably enter into class 2. So this is from the Medical Device Coordination Group that was established by Article 103 of one of the European Union regulations. It's also chaired by the representative of the European Commission, and if you go to this source here, you can look and see more information. So an example of a class 2, if it's intended for long-term use, it is considered higher risk because there's a higher chance of biofilm formation. Urinary catheters may be intended for long-term use, and they may necessitate class 2 classification. Now let's look at Australia. Australia is regulated here by the Therapeutic Goods Regulation from 2002, which is an update to a previous regulation about 10 years prior. So per these therapeutic goods regulations of 2002, there are different rules here. One is called the sub-rule 3.1. It's very similar to what Belgium has, intended to be used to penetrate body orifices. So again, that non-invasive view. This includes things such as urology. And the sub-rule here states that invasive devices that are used for short-term use, they actually identify as class 2A. So it introduce a little bit more risk, and this includes things like urinary catheters, but you might also say contact lenses. That's another thing that fits under this. Then there's short-term use. The rule here covers devices that are used in the context of surgery, so more invasive, but it's continuously for at least 60 minutes, but not more than 30 days. That's how they define short-term use. Now, if there's something that contains a medicine, this is where we distinguish from all the other classes. If something contains a medicine that can incorporate some substance that has a stable derivative of some compound, and that includes human blood and blood plasma, that may function as an assistant to the device, they label this as class 3. So if it has an ancillary action on the body, it's labeled class 3. And so any type of catheter or catheter device for urinary tract that includes some sort of antimicrobial would be considered class 3 and higher risk. So now let's look at the age of phage. Bacteriophagy as a promising approach for combating multi-drug resistant pathogens. I hope by the end of this presentation, I will have convinced you that using phage therapy studies on catheter-associated urinary tract infections is a very promising way, not only to advance treating urinary tract infections and the great global burden there, but also to advance phage therapy as a whole because of the very unique aspect of catheter-associated urinary tract infections and their role in the clinic. So, as we considered how to collectively manage infectious disease in the post-antibiotic era, some scientists and citizens and clinicians have turned to phage therapy in their search for alternative therapeutics to combat AMR bacteria. Bacteriophages are ubiquitous biological entities that parasitize bacteria in virtually every environment where bacteria can be found. There's an estimated 10 to the 31 bacteriophages on Earth. That means there are 10 million of these viruses for every star in the known universe. Phages shape much of the ecosystem, from oceans to our human bodies. For example, 30 billion phage particles move through the average human every single day. Phages can be lytic, where they actively parasitize bacteria to produce more phages until the bacteria die, or lysogenic, where they lie dormant in the genomes of bacteria. While the virome of the urinary tract is not well characterized, one study investigating phages in the urinary tract actually identified over 450 unique phage sequences, most of which were novel species in that study. At present, phage therapy is undergoing a renaissance in Western biomedicine. This has spurred substantial economic interest over the past 2 decades. Major markets of phage applications may include agriculture, water treatment plants, industrial appliances, and topical cosmetics. But in clinical medicine, phage therapy is largely unregulated, especially with medical devices. Applying phage therapy to treat recurrent UTIs may be a necessary route to advance the regulatory framework of phage therapy for 3 reasons. First, while debilitating, UTIs are rarely lethal. This enables researchers to design effective clinical trials and gather valuable data on phage therapy without compromising patient standard of care and ethics. Second, often chronic UTIs open the door for novel methods to understand the pharmacokinetics and pharmacodynamics of phage therapy, and they may generate useful data on safety and efficacy. Third, AMR-associated UTIs have sparked patient advocacy initiatives to influence policy and change regulatory processes. This is very important. This may usher in a cultural transformation for alternative precision-based therapeutics, especially phage therapy. Targeting UTIs is critical to advancing phage therapy in the clinic. By comparing the current regulatory frameworks for phage therapy in those 3 countries, the US, Belgium, and Australia, let's start to identify best practices for advancing phage therapy as an alternative method for treating UTIs. This is an overview of the journey of phage therapy. Very simplified, it's extremely complicated. First, focusing on UTIs, we believe, could be a feasible route to advancing phage therapy. These are viruses that specifically target prokaryotes, such as bacteria, and have been used to treat bacterial infections since the early 20th century. Traditionally, ideal phage candidates for therapy are lytic, which, as I mentioned before, parasitize, or after infection, these viruses actively replicate inside the host cell before lysing or bursting open the cell and releasing their progeny to infect other bacteria and restart that cycle. Modern techniques for phage therapy involve combining phages with antibiotics, referred to as phage-antibiotic synergy. Nevertheless, lytic phages possess unique advantages over antibiotics in that they are highly specific, targeting one bacterial strain at a time. They also have an auto-dosing capacity. This means lytic phages self-replicate at the site of infection. They're not static chemicals, they're active biologicals. They are dynamic. They can mutate or co-evolve with their host, and they can be utilized to effectively disrupt bacterial biofilms, that thing I mentioned in the beginning, that are almost impenetrable. They can disrupt them. Historically, most clinical trials testing phage therapy against UTIs were designed without a control group. So, further research and development are needed to evaluate the efficacy of phages to control UPEC, in particular, uropathogenic E. coli, and other pathogens. Clinical applications of phages that are most useful in treating UTIs may include enteric, intravenous, and topical. Phages can be prepared in a variety of methods, but recent prevailing arguments for phage therapy fall under three main categories. First, combining multiple phage strains into a single cocktail. We call this cocktail phage therapy. Second, engineering synthetic phages to target a specific pathogen. We call this synthetic phage therapy. Or third, combining synthetic phages into an array of different strains guided by machine learning to target a bacterial infection. We call this systems phage therapy. One meta-analysis in the research assessing historical clinical trials to evaluate the safety and efficacy of phage therapy identified several pitfalls for why phage therapy did not advance beyond early phases. One was there was limited understanding of phage biology at the time. Second, there was a poor selection from the research investigators in selecting those phages. Third, there was poor understanding of bacterial phage dynamics. And fourth, there was impure preparations of the phage. Perhaps a cocktail was contaminated. Indeed, with respect to phage therapy to treat UTIs, one common consensus around the board is that more studies are needed, especially data on pharmacokinetics and pharmacodynamics to inform optimal routes of administration. Specifically, studies are needed to optimize how phages are selected for clinical use. This means which phages work best for a traditional pathogen, such as UPEC, versus a superbug, such as an escape pathogen. How do we optimize phage antibiotic combinations? So how do we properly synergize phages and antibiotics to treat recurrent UTIs? And how do we understand the regulatory mechanisms to advance phage therapy for clinical care? How do we, in turn, establish phage therapy as a routine clinical practice in infectious disease medicine in different countries, considering their regulations? To establish phage therapy as a robust alternative in Western medicine, one effective approach is to focus on infections that are feasible both economically and ethically for research and development. This is where urinary tract infections constitute such low-hanging fruit for data generation. By focusing on phage therapy to treat recurrent UTIs, biomedical scientists will not only advance phage biology research, including the microbiome of the urinary tract, they will also improve methods for selecting phages and advance scientific knowledge of bacterial phage dynamics for other types of drug-resistant infections. Recurrent UTIs are ubiquitous. However, we can do something about it. Here on the journey of phage therapy, we see phage hunting may go to routine clinical practice possibly by the year 2050, but there are significant barriers that include things like biobanking, the safety and efficacy, the regulatory frameworks, and the incentives needed for those phage therapies. Now let's jump into specific country-level regulations. So, in the United States, phage therapy is typically run through the process of an investigational new drug application. Most of the patients treated under phage therapy, however, have been treated under FDA's emergency use authorization. This is regulated by the Division of Vaccines and Related Products. One example is the Eliminate clinical trial, which is trying to move from emergency use authorization all the way to investigational new drugs. In Belgium, they call this magistral phage preparation. It's tailored after a previous type of magistral preparation, but focused on phages. In Belgium, they do tailored phage compounding through this magistral prep. And if you want to learn about this more, go to Jean-Paul Pernet in 2018 in their study. Moving from a phage bank, where they have a seed lot of phages, to a controlled environment having active pharmaceutical ingredients or APIs, and then to a hospital pharmacy that can prepare those different phage cocktails that are needed. This is regulated as the medical devices were by the Federal Agency for Medicines and Health Products, or FAHMP. Here, pharmacists will prepare defined purified phages, and they're given per doctor's description. Third, in Australia, this is currently under experimental therapy under a special access scheme similar to the emergency use authorization scheme done by the United States FDA, but a very important protocol that was developed recently, especially spurred on by more studies on AMR sepsis to treat blood bacteria in the blood that leads to high risk of death and mortality, is STAMP. And this is standardized treatment and monitoring protocol for adults and pediatric patients. They've established this very interesting protocol that I highly recommend you look up if you're a clinician or a researcher interested in advancing this. They have phage passports that they're working on that standardizes how you select phages and how you combine phages. And they also have a group that's focused on synthetic phage, and this is regulated by OGTR on gene and therapy products. Now, it's very important for us to consider, beyond just those that are working in research and development and the big pharma, who are the movers and shakers primarily of phage therapy? Well, historically, over the past 30 years, it's been the scientists. It's been the fun phage hunters that have been advancing this. But more recently, we have advocacy NGOs, and we have patient advocacy groups trying to advance phage therapy, mostly driven by those that have been deeply affected personally and economically, in a deep emotional sense, by a family member or their individual story of antimicrobial-resistant infection or death. So advocacy groups such as Phages for Global Health are working on identifying those phages and training those that are looking for these phages for everything from discovery to characterization to how we can use these phage banks for bench-to-bedside type research. Then we have networks, groups like the Phage Directory, that are trying to understand how we collate all these people and get everyone to work on a common problem, and how we can teach each other, a big information sharing opportunity there. Then there are phage therapy centers. The Center for Innovative Phage Applications and Therapeutics at UC San Diego in the United States was the first phage therapy center in North America, established several years ago. But there are a lot of other centers all around the world, especially in Australia, spurred on by this group called Phage Australia, which you see down below is also creating a phage bank. There are infectious disease physicians who are applying for phage therapy, applying for emergency use authorization from FDA to advance phage therapy for individual case-by-case uses. And then there's also patient advocacy groups. We must never underestimate the power of patient advocacy groups. So there's a group called Phage One Voice that was established recently. I'd recommend looking into them if you're on the patient advocacy side. Industry and pharma is also a big mover because they provide a lot of the money. Locus Bio is doing that Eliminate trial, and they have a lot of funding advancing the basic phase 1 and phase 2 information for phages. Then, as I mentioned before, phage banks, including Phage Australia. There's also those that sell phage production, and so you think of things like Jafrel and other groups if you want to look into that. Then there's governance, so CarbX, these kind of government accelerators trying to move phage therapy in the field. These are very important movers and shakers overall. And I haven't been completely comprehensive, so there's a lot more to look into because the phage world is just so big, $1 trillion, I would say. So the conclusion here, despite the promising potential of phage therapy to treat AMR infections in the US, there are substantial regulatory barriers and knowledge gaps impeding progress. Clinicians, scientists, and regulators should thoroughly evaluate and consider the work being done in Belgium and Australia, particularly with medical devices and urinary tract infections, to advance phage therapy in the clinic. I propose that to advance phage therapy in the clinic, we can effectively generate data on the efficacy of phage therapy by focusing on this low-hanging fruit, which are recurrent UTIs. Very high burden, great opportunity, especially catheter and prosthetic joint-associated UTIs. Recurrent UTIs pose a substantial burden on healthcare and well-being worldwide, but the burden may differ country by country. Researchers should study the burden of UTIs on communities, then systematically assess the regulatory mechanisms and economic incentives that enable and impede alternative treatments, especially phage therapy. The US, where I live, can most likely adopt some but not all of the regulatory frameworks in Belgium and Australia, particularly the magistral phage preparation, as well as a phage passport to track phage-based biobanks. Yet, The U.S. is positioned to innovate with current regulatory mechanisms on novel methods for phage therapy to treat UTIs associated with catheters, and we mustn't forget prosthetic joints. Recurrent UTI phage therapy studies should focus on first, CAUTIs, and second, prosthetic joint infections, which we'll look into in the future. Thank you.